Thank you so much, Stephanie, for the introduction, and good evening, everyone, and welcome to 30 Years of Genetics, Understanding BRCA and HRD and Ovarian Cancer. I'm really excited to be your moderator tonight. Over the next 35 minutes, we'll take a look at how far we've come since the discovery of BRCA over 30 years ago, and how genetic testing has transformed the landscape of ovarian cancer care. We'll highlight the breakthroughs that have changed how we diagnose and treat this disease, exploring the growing role of HRD testing, and see how digital tools are helping empower patients to make informed decisions about their care and their family's health. And finally, we'll hear a personal story that shows the real-life impact of these discoveries on care and decision-making. I'm thrilled to introduce our first speaker, Dr. William Folks, distinguished scientist, distinguished James McGill Professor in the Departments of Medicine, Oncology, and Human Genetics. Dr. Fuchs serves as Chair of Human Genetics at McGill and is Director of Medical Genetics at both the Montreal Jewish General Hospital and the McGill University Health Center. With more than 3 decades of conducting research, he has made unique contributions and discoveries in cancer genetics. He has led studies that defined how to treat BRCA-related cancers clinically, and his research team has discovered and characterized several cancer predisposition founder mutations in Montreal populations. Welcome, Dr. Fuchs.
Hello, can you hear me okay?
Yes, we can hear you. There you go.
Great, okay, so thanks for that kind introduction. So I'm just going to try and share my screen. Let me just how does that look? That's not the you want to see the slide view, don't you? Yeah, from the beginning.
Yes, that one.
Let's try that one. How's that? Is it okay?
Yes, now it is. I see it.
Great. Okay. So in the next 10 minutes, I'm going to give you a quick run through some of the advances in genetics over the last 30 years as part of this national symposium. So the first thing I think to point out is what am I going to talk about? Discovery of BRCA1 and 2. How did these findings influence management of risk for and treatment of ovarian cancer, and a little bit about HRD testing, particularly in the context of therapy. So BRCA1 and BRCA2 are by far the most important ovarian cancer genes. In 1900, typo, 1990, Mercury linked familial cancer to a gene on chromosome 17q that she called BRCA1. It was then undiscovered. Stephen Nayrod, now in Toronto, but at the time in France, showed this gene increased the risk for breast and ovarian cancer. So both breast and ovarian cancer were found to be linked. And after a 4-year chase, the gene was found by Myriad in 1994, and in 1995, BRCA2 was found. Things went quiet for a bit, but then in 2007, PALB2 was associated with breast cancer and later with ovarian cancer. And meanwhile, 3 other genes had been found to predispose to high-grade serous ovarian cancer. Lynch syndrome, which is another type of syndrome, doesn't really predispose to high-grade serous cancer, and the risks are lower, but it does predispose to endometrioid and clear cell ovarian carcinoma. So what are the risks for ovarian cancer if you have a pathogenic variant in one of these genes? And they are substantial for BRCA1 and 2. That's the important point. These are the risks for ovarian cancer shown in green, so 30 to 50% risk for BRCA1, 10 to 20% risk for BRCA2, and about a lower risk, 3 to 5% for PALB2. And you see the breast cancer risks are pretty substantial, of course, and the genes were called BRCA because of the breast cancer link. But the ovarian cancer link, particularly for BRCA1, is very, very strong. And in fact, about 20% of all ovarian cancer can be attributed to mutations in those genes I just mentioned. So it's by far the most hereditary common cancer, much more hereditary than breast cancer, much more hereditary than lung cancer, for example. What are your risks? So it depends how old you are and what gene you have. You see here BRCA1, if you're 30, your risks are almost unmeasurably low. But if you're 50, your risks in the next 30 years go from about 10% up to about 45%. So that's a big jump over that period. BRCA2 starts later, very low risk before 45, but then gets to be quite substantial, although never as high as BRCA1. But these risks are enough to justify preventive removal of the ovaries around about the age of 35 to 40 in BRCA1 and 40 to 45 for BRCA2. And that's comparing BRCA2 and BRCA1, so a much higher risk for BRCA1. What about these other three genes I mentioned? BRIP1, RAD51C, RAD51D. As you can see here, the risks are quite a bit lower, 11% for RAD51C, 13% for RAD51D, and about 6% for BRIP1, but they're still substantial. And you put all these together, as I say, it accounts for about 20 to 25% of all ovarian cancer is accounted for by mutations, by inherited mutations in these genes. Another fraction is caused by mutations that just occur in the cancer and can't be transmitted to the next generation. But overall, we can see these are substantial players in ovarian cancer. And what do they do? Well, I'm not going to go through this, obviously, but just to make the point, it's quite complicated. And you will notice that RAD51 is seen here, and some of the other genes are seen to be binding to BRCA1. So BRCA1 and 2 essentially have multiple functions, but the one that's most important is related to DNA repair. So you see multiple functions here, but the one that really is important is involved in DNA damage and this thing here called homologous recombination. HRD stands for homologous recombination repair deficiency. So that's the part of the where BRCA1 is really important. And as you can see, they all actually bind to each other. So all these genes are actually kind of related. Here's BARD1, another gene that doesn't mainly cause ovarian cancer, but does cause breast cancer. BRCA1, PALB2, BRCA2, RAD51, BRIP1. So they're all kind of together as a complex, which is all involved in repairing broken DNA, shown here. Okay? And essentially, when you get a type of DNA damage, shown here, for example, where both strands of the DNA are broken, as you see here, both strands are broken, it has to be repaired by something. Otherwise, you'd be in big trouble. And that's done by BRCA1, essentially. So BRCA1 repairs those breaks, and BRCA2 repairs those breaks. If you don't have that repair, the cell will get into big trouble and might either become cancerous or might die. And it's been known for years that there's individual variation, of course, in how you respond to treatment. And it's more recently been recognized that genes that influence the risk for ovarian cancer also influence the effectiveness of therapies. So there's two reasons they get tested, not just because you want to know, whether other people in your family are at risk, but actually to affect your own treatment. And that's the connection. It's between DNA, it's DNA repair that links BRCA1 and BRCA2. It's the link between triple negative breast cancer and ovarian cancer, for example, which both respond to DNA damaging drugs like cisplatin. And it's really exploration of these functions that led to this important new treatment. Because if you force a cell to go down an alternative repair here, because you block one side, because HR is blocked, because you don't have BRCA, you get alternative repair, which is actually a mistake. So it makes mistakes in cells. So in BRCA deficient cells, you get this kind of gross instability of the cells essentially die. So if you can force a cell to go down this pathway, then that would be a way to try to treat them. And essentially, that's what the drugs, so-called PARP inhibitors, do, in that they force the cell to go down a pathway which isn't functional because the drug blocks the pathway. So you have one pathway that's blocked because of a mutation, and the other pathway is blocked by a drug, and the cell can't cope with it. And you can see here the cell dies, but it doesn't really affect a normal cell. It only affects a cancer cell, because only in a cancer cell is the homologous recombination repair deficiency completely present. It's only really deficient in the cancer cells, not in your blood cells. So the first big win, in fact, was the treatment of ovarian cancer with olaparib, which is one of the PARP inhibitor drugs. And what they showed was that it pushed survival out by quite a long time. It wasn't a huge effect, but the point was there'd been no real advances before this drug. So this was the first study to show a differential response if, in other words, you responded better if you had a BRCA1 mutation than if you didn't. And that was a big news because then people would want to be tested. And it was written at that time that this crucial shift from genetic testing for risk assessment to therapeutic advantage, that was thought to be not very far away. That's written over 10 years ago. And in fact, it's turned out that this is in fact the case. That in fact now you can see here in these follow-up studies, you can see here quite big differences between people who got olaparib, shown in red, and those who didn't in blue. And this is quite a big difference. This was maintenance therapy, 5 year follow-up of people who were taking the drug for 2 years, and you can see substantial benefits. And these results supported the use of maintenance therapy as standard of care. This was a very important paper, followed by another paper which was used in people who'd relapsed from ovarian cancer. Okay, so they'd already had a response, but then the cancer came back, and in those persons, you can see here that there's a difference between, again, placebo shown in red and olaparib shown in blue. You have to adjust a little bit. This is adjusted because some people were allowed to switch to olaparib when they relapsed, which obviously meant, you know, the responses were actually better than they look, and it had to be adjusted because almost over a third of patients actually got olaparib, even though they're in the placebo arm. So that can obviously make things a bit different. And you can see this is a 26% improvement in the hazard ratio for survival, which is, which was thought to be significant and important. And although, as I say, it was sort of traditionally statistically significant, but it was thought that the findings were meaningful, and maintenance olaparib is now standard of care, I think, in Canada and the United States and much of Europe. From to the next slide. Whoop. Oh, there we go. Oh, yeah. Sorry. It's a long slide. So I wanted to finish in this short run through just to show you how things have evolved since 1990, okay, when I said the BRCA1 was linked, and now at 2020, so that's your 30-year timeline. Here's BRCA1 and 2 identified in 1994 and 95. And not that much long after, you can see that PARP inhibitors were first discovered, 2005. So that's 20 years ago. And leading quite quickly to trials that showed that the drug was working. And this really is homologous recombination deficiency being exploited by a drug that acts on cells that lack that. HRD can also be measured in other ways using other types of tests. But it's really the presence of BRCA and related genes, mutations in those genes, that makes the big difference in terms of therapy. So you can see we've got to 2025, and now these drugs are widely available and trials are continuing. But I think you can see that it's been an interesting 35 years with really quite substantial advances that have happened because of research that was done in Canada, in the US, around the world by women and their families who were able to support the research by donating samples and enrolling into studies. So obviously that's a tremendous collaborative effort between the scientists, the patients, families, and the physicians. So I think I'll stop there. I think my time is probably up, and I'll be happy to take any questions later on.
Yes, thank you so much, Dr. Fuchs, for setting the stage with that incredible overview of how genetic discoveries have really revolutionized ovarian cancer care, and ending with that nice timeline. That's a nice illustration of how far we've come. Next, we'd like to shift from discovery to innovation, exploring how technology is helping make genetic testing easier to navigate and more patient-centered. Dr. Yvonne Bombard will share how digital tools are empowering patients through their throughout their genetic testing experience. Dr. Bombard is a professor and a Canada Research Chair in Genomics Health Services at the University of Toronto. She directs the Genomics Health Services Research Program at St. Michael's Hospital, Unity Health, Toronto. Her work focuses on evaluating the outcomes of genomic technologies for patients and healthcare systems, developing digital tools for genomic medicine, and engaging patients in health technology assessment. Please join me in welcoming Dr. Bombard.
Hi, everyone. It's a pleasure to be here and join you all today and share a little bit about what we've been working on to carry through how these amazing discoveries that Dr. Fuchs had overviewed so nicely can then be translated into the clinic. And my group at the University of Toronto and St. Michael's Hospital focuses on how we can bring these technologies and best deliver them in our healthcare systems and what tools and resources need to be built to support patients and empower them in these genetic testing journeys. Because as we know, genetic testing can be very actionable and can lead to different kind of therapies that are being targeted for a patient's tumor and their best management. And it's important to empower patients into their healthcare journeys. But there's only so many people in our healthcare system, and there's alternative resources that we can turn to, and those are digital tools that I've been developing with my group. So I just wanted to say that the Genetics Advisor, these are my disclosures, and I will be talking about the Genetics Advisor, which was developed in my lab and now is a standalone company that is supporting both cancer genetic testing and other forms of genetic testing around the world. So, you know, why do we work on these kinds of tools? And I think I mentioned off the top is that, you know, the use and the utility of genetic testing is growing, and we're meant to be, and oncologists are meant to be using genetic testing as a first line to also inform care and the best treatment and targeted therapies for their patients. But as you can imagine, there's not as many genetic professionals and experts out there to support all the genetic testing that's happening. And this is a nice clip summarizing the fact that there is a lot of genetic testing that's being ordered and really can advance patients' care and their outcomes. But there is just a shortage of work in our workforce on the genetic side in terms of the expertise of geneticists like Dr. Fuchs and other genetic counselors to actually support patients who are having genetic testing more routinely now to tailor their therapies and tailor the choice of management strategies. So in many parts of genetics, we've been using actually for the past 20 years, digital tools such as web-based portals, chatbots, other software, videos, books to actually intervene and actually support many different parts of the patient's genetic testing journey, whether it's to support healthcare professionals who are gathering family histories and going through family trees, reflecting on some of the risks and the risk assessment, or trying to even do education and genetic counseling and weigh up the pros and cons of undergoing genetic testing and what the tests might mean for both the patient's care as well as implications for families and life decisions, to even helping support the return of these types of complicated technologies and technical information and make it patient-centered and help initiate and support patient management and the referrals that continue on. So in my evidence-based research practice, it's really to try to make sure that the kinds of tools that we're using both in healthcare practice and with patients meet the kinds of rigor and standards and are valid in ways that we know to improve information, education, and meet patients where they are, make sure that they enhance patients' care experiences, and actually improve outcomes, whether that is, does that support patients' decision-making, use of and adherence to certain recommendations and possible surveillance strategies, and even support them on the therapeutic journey. And then system level considerations in terms of, do these types of digital tools that we use with patients and physicians in the clinic, does it support more efficiencies and reduce wait lists, for example, and support patients in those shared decision-making, potentially stressful conversations with their healthcare providers? And then ultimately, does this improve these type of digital tools? We are using them more broadly and to engage in with communities potentially geographically dispersed in rural, remote communities, or those who aren't as comfortable engaging with the healthcare system. Do these expand opportunities to access those who might be medically underserved to date? So actually, genetic counseling PhD students in my lab had actually undertook a systematic review to actually review what the evidence shows out there in literature about using these types of digital technologies in genetic testing and the delivery of those care models. And they had actually identified 70 studies and 70 studies, 70 tools and 87 studies. And they had collectively indicated that the use of these tools have actually improved several different kinds of outcomes and processes and patient-centered care experiences. Specifically, the use of digital tools in clinical practice when offering genetic testing and helping patients support what these tests mean and what they mean for their care had actually advanced family communication and explanations within families, helped patients navigate the next steps in their treatment journeys and how to manage their care, and help them potentially make healthier lifestyle and other choices in terms of their behaviors, helped actually support psychological well-being in terms of anxiety, distress, and uncertainty that might come with both cancer genetic testing and also understanding what the results mean for their care. And also engage and empower patients and feel that they are active agents and have a level of control in their cancer journeys and their cancer genetic testing journeys specifically. And also help decision-making vis-a-vis having a genetic test, taking up a certain recommended therapy or surveillance strategy that's recommended, as well as support patients' knowledge and understanding and make them an empowered, informed person in that decision-making triad, if you will. And of course, some of the ways that, as I said off the top, do these tools, when we introduce them into clinical care and support the health system to actually deliver and improve access and outcomes and patient centricity, does it actually help providers as a secondary outcome? And in fact, provider satisfaction was actually exceedingly high, as well as the willingness to incorporate and integrate these kinds of tools into their practice and workflows. And in fact, 7 out of the 10 studies that looked at efficiencies and wait lists and time reductions and actually seeing either a physician or the amount of time the physician was spending in terms of explaining basic concepts to engaging in more patient-centered dialogue actually also showed efficiencies as well. So it's all very good, and from a health policy perspective, to know that we have an evidence-based medicine and we've looked at the risks and benefits of delivering and integrating these new types of tools. But sometimes it's hard to understand what these tools are without an example. So here, if you'll indulge me, I'll talk about the tool that I built over the last 15 years in my lab, and that has, as I mentioned, has been now available in practice as a commercial product. It's called Genetics Advisor. And it is, again, meant to support both patients as well as providers. If it's patient first, and it's built by patients for patients with clinicians to support the minute that patients are onboarded and referred for genetic testing, and help them explain why they've been referred for genetic testing, help collect the family history and information from their family trees to inform their genetic counseling consults, support them with multimodal forms of education in terms of videos and patient stories and vignettes and different FAQs, and even simulate some of the decision-making that a genetic counselor would actually undertake with a patient, thinking about the pros, the cons, and the implications for life decisions, medical decisions, and family implications. It can then take consent using patient-centered plain language, and then actually return results with the support of the care team in, again, patient-friendly summaries with the medical recommendations that their medical team would provide to them. And then support post-test explanations, what the next steps are for their care journeys, and even ongoing communication should there be updates to their genetic test results over time that need to be communicated. For providers and the healthcare system and the medical management team behind the scenes, they're absolutely tracking the patient's progress, notified when the patient's consenting, if this is used as a consenting tool as well, and can help deliver results using our patient templates and friendly language, and then ongoingly support them with ongoing supports if that's how the clinic decides to use them. The advisor is something that a clinician or a physician's office or a department would take on and would offer that as a service to their patients that they're providing genetic testing to. I'm usually asked that, so I'm just explaining that this isn't something that a patient or a member of public would just jump on and order testing. This is meant to support the care team and providing patient-centered tools to bring the patient along in their care journeys. In our evaluations of Genetics Advisor, similar to the summary and the systematic review of the evidence that we saw, we actually ran it through randomized clinical trials with cancer patients. And we had half of the patients use the Genetics Advisor and then speak to a physician or a genetic counselor, or just speak to a clinician as the control arm. And what we actually found that there was significant improvement and high reports among the patient group, cancer patient group that used the Genetics Advisor, in terms of them saying it's acceptable, high levels of satisfaction. There was significant improvement in knowledge and understanding of what genetics and cancer genetic testing meant, as well as a reduction in the time spent to see during the consult with the physician. Now, that didn't come at the cost of the quality of care that was provided to the patient, and that was actually a major focus of mine always, as first as the patient, but also making sure that we could be more efficient in the consult and maybe actually open up the opportunity for more patients to be seen by those clinicians. But it was never at the expense of the patient experience, because what we did was also audio record the sessions with the clinician and the patients. And what the analysis of those audio recorded sessions revealed was that patients that used the Genetics Advisor before talking to their physician or genetic counselor actually were the ones driving and talking the most in their sessions. And quite literally, if you look at the transcripts and the pages comparing the control arm to the physician or the Genetics Advisor arm, you can actually see that the patients in the driver's seat doing much of the talking, and in an informed way, drawing on the concepts from the educational component of the advisor, actively trading off and deliberating the pros and the cons and their own preferences and their own perceived harms and benefits in their calculation, and then also reflect on their own lived experience and their own personal circumstances to reach their own decisions and support their care journeys. And this is actually the fundamental tenets or components of patient-centered care, suggesting that it is actually a tool that not only improves knowledge and efficiencies in terms of our system delivery and be able to scale the delivery and access of genetic testing, but it comes with an enhancement in patient-centered care as well when delivered with a clinician. Outside the trial, we've seen the same kinds of outcomes sort of established in different settings in different health systems, as well as with different patient groups. And again, we're seeing some of that time savings in the time spent with a physician, but actually, again, very high levels of patient satisfaction, consent rates, feeling empowered and engaged in the conversations, knowledge being higher, as well as that emotional support being actually provided through the platform and then reinforced with the clinical team. Of course, just to reflect that we have to stand back and think about, how we use digital tools in our medical settings and to support patients as well as clinicians. And certainly some of the evidence base, both from Genetics Advisor as well as the broader systematic review of the literature, shows that we can use these tools to advance patient-centered care and shared decision-making. Those are what those letters stand for. And that can have not only patient improvements in care and their outcomes, but also potentially system efficiencies in terms of reducing wait times and making the consult times more efficient, patient-centered, and effective. But we always have to think about what might be the unintended consequences, and keeping cybersecurity and privacy always at the front of mind, and certainly is a major focus of health systems, of hospitals that bring in these technologies. And I've witnessed them myself as these systems bring on Genetics Advisor, that it goes through very high rigorous standards, but something that we always need to keep in mind, as well as equity. When there's always questions of who has digital literacy, who's able to have the technology, the broadband or Wi-Fi access, and who is able to be supported by these type of tools, but recognizing that high touch and high tech could always be coupled and should always be coupled with low tech. And whether that is maybe using these tools with the populations that can and want to engage with them, and then freeing up the time and the channels for those that don't want to use these tools or can be served in other ways. And that way we're finding actually resource allocation and making those decisions in an effective way. And it's always important to think about how, and definitely in the way that we design and implement these type of tools, is that these are co-designed with patients, for patients, and centering on their needs with, of course, the required clinical validation as well as the medical guidance that is provisioned by the clinicians that we co-design with, and making sure that when we deploy these kinds of tools in the system, that we're always learning and we're iterating and improving and trying to always learn as we go, and not make sure that it's just a static type of tool in the system. Just a quick end with thanks to my team, wide set of collaborators, as well as the funders of our research. And I'd be very pleased to answer any questions in the discussion. Thank you very much.
Wonderful. Thank you so much, Dr. Bompard. It's really inspiring to see how digital tools are being integrated into the care pathways and how they're enhancing patient experience and really providing that meaningful support along the way. Next, I'm honored to introduce Dr. Nyree Rosenberg, a previvor advocate. Dr. Rosenberg is a family physician living in Toronto. As a medical professional who lost her mom at an early age to hereditary ovarian cancer, she is passionate about spreading awareness by sharing her personal experience navigating living with a BRCA mutation. Welcome, Dr. Rosenberg.
Thank you so much. Thanks for having me. Hopefully everyone can hear me okay. So good evening, everyone. My name's Nyree Rosenberg, and it was a pleasure to be invited to speak with you and share my story. A bit about myself. I'm 32 years old, Ashkenazi Jewish, and was born and raised in Vancouver, BC. I moved to Toronto 6 years ago, where I matched for my family medicine residency, and I'm now a practicing GP here. My journey and connection with ovarian cancer began when I was 9 years old, when my parents told my two older siblings and I that our mom had just been diagnosed with likely ovarian cancer. About 1 year earlier, my mom had been contacted by a first cousin who had tested positive for BRCA1 mutation after she was diagnosed with breast cancer in her 50s. That cousin had sent out an email advising all the members of the family to pursue testing. At the time, my mom and dad had gone to the BC Cancer Agency hoping to get tested, but they were told that it wasn't yet covered and to kind of look back for future studies and things like that. A few months later, my mom developed pelvic pain, and she attributes going to the doctor right away because of having this higher index of suspicion that she may carry a gene that might increase her cancer risk. Thankfully, her family doctor was amazing and took her concerns very seriously. They worked her up promptly, and within a week, she saw a gynecologic oncologist for a concerning ovarian mass, who suggested she go right ahead with surgery given this possible history. She had her hysterectomy, bilateral salpingoophorectomy right away, and her pathology did come back positive for grade 1 high-grade serous ovarian carcinoma. Soon after that, she did also test positive for the BRCA1 mutation. And unfortunately, as many of you know, ovarian cancer is one of the most difficult cancers to treat. She did end up having recurrence 3 years later after she had gone through chemo, radiation, and surgery. And the second time around, her cancer didn't really respond to treatment, and she passed away a few months later in June 2006, over 19 years ago, when I was 13. A bit about my mom. She's my biggest inspiration. She was extremely courageous and strong throughout her journey, and she was very hopeful and an advocate that over time there'd be better treatments and research and genetic testing availability so that others would be able to hopefully prevent going through what she did. For me, it was always something I knew I would want to do eventually, to get tested for the BRCA gene. But for me, it was a bit more a matter of when and timing, because I, was aware of this risk when I was quite young. I wanted to wait till I could get tested and take action and do something about it versus just sitting with the anxiety. I have an older sister, 3 years older than me. She was the first one to get tested, and unfortunately, she did test positive for the gene. She started breast screening in her 20s. And then finally, during the pandemic, I got organized and got tested and was quite shocked when I too was positive for the BRCA1 mutation. And even knowing that it was a possibility, it was quite emotional finding out that for sure, this was something I was going to have to deal with, and all these decisions I was going to have to make. And it wasn't like a theoretical risk anymore. For me, having the BRCA gene is all about risk tolerance. I'm not very much a risk-taking person, quite risk-averse and more conservative, and that will be reflected in kind of the decision-making that I have made. But of course, there's no one size fits all, and everyone needs to do what feels right for them after being informed of all the options. But because I lost my mom at a young age, had such a big impact on me, and working in the medical field, seeing a lot of people go through cancer, I've always been aware of, the worst case scenario and the deep impact that can have on one's life and one's family. The first thing for me was to consider having a mastectomy to reduce my breast cancer risk. I just wasn't sure about timing, whether to wait till after children or not. But this decision was made a bit easier when my older sister was diagnosed with ductal carcinoma in situ on a screening MRI in her late 20s. Seeing her go through this scare and having to wait for pathology and all those types of things made me realize I just wanted to do it right away. So I did that, a bilateral prophylactic mastectomy with reconstruction in March 2022. Because this is focused more on the ovarian cancer piece and it's a short talk, I'll move ahead to kind of the future other decisions I made. So after completing my breast surgery, the next thing I thought about was family planning. And I was trying to decide what to do, whether to go through IVF in order to select embryos that don't have the BRCA gene and implant those versus getting pregnant naturally, and went back and forth for many years. My sister lives in the States. It was very costly to go through that process, so she decided to have kids naturally. She has two beautiful, healthy children who will, once they're 18, have the option to decide whether to get tested or not. After lots of back and forth, I decided that for me, what felt right is to go through the IVF process to try and get rid of this gene and not pass it along. And we're lucky in Ontario that the government will cover one round of IVF. It doesn't cover the genetic testing or the medications, but so I got on this wait list. And yeah, in good news, I am pregnant now, 23 weeks, and I have a female fetus who is BRCA negative, or 99% chance BRCA negative based on pre-implantation genetic testing. So it gives me a lot of comfort knowing that hopefully this is something that my family won't have to, or my future daughter won't have to deal with. A few months ago, my sister had her bilateral salpingoophorectomy to prevent her ovarian cancer risk at age 35. She's doing really well now. Her pathology was clear, which was a very emotional moment for all of us. But yeah, I think, just showing that for all of us, the journey looks different, but being really grateful, that for us, we knew about this risk since we were young. We're able to take action on it. It's definitely not an easy process, and, has been challenging for sure throughout the way. But I know our mom, wishes she would have had the same opportunity. And so I feel very grateful for that and really appreciate you having me here, and happy to answer questions.
Wonderful. Thank you so much, Dr. Rosenberg, for sharing your experience and such a powerful and personal story, and a hopeful story as well. So thank you, and congratulations on your pregnancy. I'd like to invite the panel back on video, please, and we can start the audience Q&A. So I'd love to open the floor to our audience. If you have a question, please, for any of our speakers, please enter it in the Q&A box. I'm already seeing lots there, so we will try to get to as many as we can. The first one is for Dr. Fuchs. Can you just elaborate on, are all BRCA1 carriers positive for HRD? Just maybe elaborate on that.
It depends what you mean. I mean, all BRCA1, so a BRCA1 carrier is somebody who has the BRCA1 mutation in one of the two copies of their BRCA1 gene. So the carrier themselves don't have HRD. The tumor, if it lacks the second copy, let's say you inherited the BRCA1 mutation from your mother, so your mother's copy of your two copies is abnormal from conception, then the other copy, your father's copy, let's say that goes missing over time as like brakes on a car, it gets worn out and it doesn't work anymore. Then the tumor will have HRD. But if the tumor doesn't have a second hit in BRCA, in other words, just the one you inherited is not working, then the tumor probably wouldn't have HRD, and it's possibly why the drug stops working or never works. It might never work if you don't have HRD, right? And it
Mhm.
might stop working if the BRCA1 protein in the tumor starts to be functional again, which can happen. It's called reversion. So you get
Mhm.
reversion mutations. So that's kind of, I hope that's the answer to your question. It's a good question. Most ovarian cancers in a woman with a BRCA1 mutation will have HRD.
Yes, and I think it's you made it clear more that we're talking about the tumor that's HRD positive, right? Versus the person, right? The carrier.
Yeah, the person can't
Yes.
be HRD.
Yes. Yes.
Fortunately, people are very rarely HRD positive.
Yes, and I think that was the
Yeah,
distinction.
the tumor in the
Okay.
person. Yeah,
Yeah.
yeah.
Wonderful. Okay, so I actually have a question for the whole panel. There's still a small risk for ovarian cancer post risk reduction surgery. Therefore, should there be some sort of continued testing like ultrasound, MRI post risk reduction surgery for those who are BRCA1 or BRCA2 positive? I don't know who wants to take that one.
I mean, I can try. I don't want to hog the hog the. If Nivert wants to answer, that's fine. I mean, my answer would be. I mean, it's a natural question to think, isn't it? I've had the surgery. What are you going to do now? But there's not really much evidence that anything really helps. In fact, I mean, there was
Mhm.
a study a long time ago from the Netherlands where they followed up people and did ultrasounds and so on, and they stopped doing them basically. I mean, there's always a case that you'll hear about where somebody had an ultrasound or a C125 and it made a difference. But for most people, once you've had the surgery, that's it. I mean, it's a demedicalization procedure, if you like. But it's certainly true that if you're going for a bilateral self-injury oophorectomy, to reduce your risk, it's certainly true that the older you have the surgery, the more likely you are to have disease that is already escaped from the fallopian tubes before you had the surgery. So there may be a case, I guess, for watching people who have the preventive surgery at a later date than would have been normally recommended, like in their 50s rather than in their 30s or 40s, as I showed in my diagram. Um, but but I don't think there's much evidence that surveillance actually helps anybody. It may make people feel better. It may feel psychologically helpful. It may make the doctors
Mhm.
feel like they're doing something, but I'm not sure that there's any evidence it actually saves any lives.
I have another question for the whole panel. This person says, I learned that there's a global research study about the length of time for the use of olaparib that's supposed to be released in October. Does anyone have any information on that? Apparently, it included Canada in the study. No, I'm seeing no. Okay, so OCC will look into that and hopefully be able to answer any of those questions. And it's still
Yeah,
up,
I
so
mean,
we'll see.
some people have been on olaparib for years,
Mhm.
and I think there's no suggestion that you should stop it. Actually, I mean, I don't think there's a clear answer. If I mean, it's a tricky one because if you've had ovarian cancer, then you're more likely to you will have had platinum, and it's those people who've had platinum that tend to get the complications of olaparib, such as myelodysplasia and so on. So perhaps long-term use might increase the risk of that. But I think for many people, particularly if they haven't had heavy dose chemo, they might be reluctant to stop it actually.
Mhm. Okay, let's see. We have lots of questions, and I'm sorry, I don't think we're going to get to all of them because there's so many. But I wanted to have another one here. It says, "Is the majority of ovarian cancer research targeted at those with genetic causes? I have mucinous ovarian cancer with no genetic markers, and I feel like I've never heard about research in that area." Um, Anyone want to talk about more of the rare ovarian cancer types? I know, Doctor. You do small cell as well, so I feel like that one might be to you again.
Well, I mean, the point about okay, so mutations of ovarian cancer is certainly an important diagnosis, tends to can have a poor prognosis depending on whether it's recurred or not. The reason it hasn't had as much research is it's not particularly frequent. And it doesn't have, it's the one ovarian cancer that's definitely not linked to BRCA1, 2, and the other genes I mentioned. So I think it's perhaps been a bit of an orphan in that respect. And there hasn't been as much research. I agree with you. Uh, but it's tricky because you have to, to do research, you need a lot of people to actually accumulate patients to do trials, for example, and that can be tricky with very rare ovarian forms. It is one of the rarer forms of ovarian carcinoma. So I think I'm sure OCC are very aware of that and are looking at ways to fund the research, but it's not one of the diseases that stands out because 70% of all ovarian carcinoma is high-grade serous cancer of the ovary, and the prognosis is generally poor, as you all know. So I guess people naturally put the money, in a disease which is common and has a bad outcome. And it just so happens that it's one of the most hereditary adult cancers of all, probably the most hereditary. So you can see that it's kind of like all those things go together. And then there's a drug that works. So it kind of, it makes sense that that area has accumulated a lot of interest, but not to say that mucinous cancers don't deserve, deserve research dollars as well.
Agreed. Yes.
Just to say, if people do have I'd be happy to. You can Jessica, you can just forward the emails to me and
Yes, I think I will because
Right.
there's lots of questions on
Yeah,
HRD and
I saw them. Yeah,
BRCA.
I'm happy to
I don't
have a.
think we'll get to all of them, but I did want to just ask Dr. Bombard a quick question because this is an easy one, I think. Does BC Cancer Hereditary Program use your genetic advisors tool? BC people want to know.
Yes, they have been using it and they are going to be using it some more. So yeah.
Wonderful. Okay, that's great to hear. And I did have one for Nairit, and we're gonna wrap up in just a minute or two. So I just wanted to ask Nairit, what's one piece of advice that you would give someone considering genetic testing?
Um, I think that even though it's kind of nerve-wracking to consider the genetic testing, I always do encourage people to do it. And I try and tell them, like, just because you get the genetic testing, you don't have to act on that information. It's just basically, even like in my mom's scenario, like when she didn't even know but there was an inkling, like sometimes that's going to change how you respond to changes in your body or things that you're doing. So I think just remembering that just because you have it, you can choose to do nothing about it, and that's okay too. But trying to get that information, it kind of touches upon one of the first questions Dr. Folks was answering. I had a patient asking me for pelvic ultrasound for ovarian screening the other week who had a maternal history. And I spent a long time trying to counsel about, that we don't really have good evidence for this. So to me, encouraging them to go to genetics, talk to them and see about getting tested, because we have effective ways to prevent ovarian cancer, through surgeries and things like that. My concern is if people don't go for those tests and instead do, let's say, ultrasound surveillance or things we don't have good evidence for, and that comforts them, that's not the effective treatment, So just, I think, going for it, it's nerve-wracking, talk to people, gather as much information as you can. And then that's why we have genetic counselors who are amazing resources once you do get tested to have those types of conversations with.
Thank you. So we are at the end of our session. So I just want to take a moment to thank our incredible panel, Dr. Folks, Dr. Bombard, and Dr. Rosenberg, for sharing their expertise and their experiences with us. And thank you all for the wonderful questions. And I hope we can get to all of them eventually, and for really engaging in this important conversation. So before we wrap up, we'd love to hear from you what else you'd like to learn more about. So please take a moment to respond to the poll that should be popping up on your screen right now. And thank you, and enjoy the rest of tonight's sessions.